Hello friends. Now we will going to discuss about Nstemi part 2. In this we will discuss mainly about the treatment part. The treatment objective for patient with the Nstemi ACS are focus on stabilizing acute coronary lesion, treatment of the residual ischemia and long-term secondary prevention. Antithrombotic therapies like aspirin, P2Y12 ADP receptor blockers such as ticagrelor, prasugrel, clopidogrel, anticoagulants, glycoprotein 2b3 inhibitor are used to prevent further clotting in the coronary artery and allow the endogenous fibrinolysis to dissolve the thrombus and reduce the degree of coronary stenosis. Antithrombotic therapy is continued long term so that if a future event occurs, the degree of thrombosis is reduced. Anti-ischemic therapies like beta blocker, nitrate, sometimes calcium channel blocker are used to reduce the myocardial oxygen demand. Coronary revascularization is frequently needed to treat the recurrent or residual ischemia. After stabilization of acute event, the many factors that led up to the event need to be addressed. Treatment of atherosclerotic risk factors such as hypercholesterolemia, hypertension, and smoking, which contribute to the stabilization of cholesterol-laden plaque and healing of endothelium, is critical. Now, regarding antiplatelet therapy, though the first therapy is aspirin. Aspirin is the cornerstone for therapy for patients who present with Nstemi ACS. Through irreversible inhibition of cyclooxygenase, aspirin decreases platelet activation and has demonstrated the clear beneficial effect for patient present with Nstemi ACS. The randomized clopidogrel and aspirin optimal dose usage to reduce the recurrent event, seventh organization to assess the strategies in ischemia syndrome, that is current OSS 7 trial evaluated 25,086 ACS patients and demonstrate no difference in outcome between low dose aspirin, that is 75 to 100 mg, and high dose aspirin, that is 300 to 325 mg. Importantly, each arm receives an initial loading dose of aspirin of at least 300 mg on day 1, and the results were similar for pre-specified subset of the individual who underwent PC. A subsequent meta-analysis demonstrated a comparable benefit between low dose and high dose aspirin. That is, low dose, that means less than 160 mg, and high dose means greater than or equal to 160 mg of aspirin, with increased risk of bleeding in the high dose group. Thus, for patient presenting with Nstemi ACS, the initial loading dose of non-entry coated aspirin, that is 325 mg, followed by maintenance dose of 75 to 81 mg daily, is a reasonable approach. For patient with allergy to aspirin, the loading dose of clopidogrel followed by daily maintenance dosing is reasonable alternative. Now, the next class of drug is P2Y12 adenosine diphosphate receptor blocker. So the clopidogrel is the thienopyridine derivative that inhibits the platelet activation and aggregation by irreversibly inhibiting the binding of ADP to P2Y12 receptor on the surface of the platelet. So in clopidogrel in unstable angina, to prevent a recurrent event trial, that is cure trial, the addition of clopidogrel plus aspirin led to 20% reduction of recurrent cardiovascular event when compared to aspirin alone in 12,562 randomized Nstemi ACS patients. For patients who underwent PCI, those treated with clopidogrel experienced 30% reduction of ischemic event, and the combination of clopidogrel plus aspirin was, however, associated with relative 35% increase of major bleeding, but absolute increase was only 1%. Furthermore, using the standard TIMI definition of the bleeding, there was no significant increase of major bleeding risk and no increase of intracranial hemorrhage. Clopidogrel is an active product that requires the hepatic metabolism via cytochrome P450 system to produce the active metabolite. So roughly 85% of the product is hydrolyzed to inactivate metabolite by circulating esterase. There are several notable pharmacogenetic and drug-to-drug interaction for clopidogrel that can affect the patient's outcome. Approximately 25% to 30% of population has reduced function genetic variation of CYP2C9, which is a member of CYP450 enzyme family. When treated with the clopidogrel, these individuals have lower circulating level of clopidogrel active metabolite, thereby leading to less platelet inhibition and higher rate of ischemic event, including stent thrombosis. So the two randomized trial, that is Taylor PCI and Popular Genetics, tested the genotype guided strategy for P2Y12 inhibitor selection. Taylor PCI found that in patients with CYP2 C99 loss of function allele, ticagrelor tend to offer larger relative risk reduction in ischemic event over clopidogrel as would be expected. And in popular genetic, allowing clopidogrel to be used in patients who did not have CYP2 C19 loss of function alleles, giving ticagrelor in all other resulted in comparable ischemic outcome compared with strategy of ticagrelor for all and reduce the risk of bleeding. These data have not been adopted in practice guidelines. So metabolism of the clopidogrel may also be affected by certain drugs. Several pharmacodynamic studies had shown that PPI that inhibits CYP2C9 could decrease the clopidogrel activity. However, the safety of combination therapy with clopidogrel and the omeprazole was demonstrated in clopidogrel and optimization of the gastrointestinal event trial, which randomized patient to clopidogrel alone or combination of the clopidogrel plus omeprazole following PC. So there was no difference of cardiovascular outcome over 6 months, although the significant reduction in GI event among patients taking PPI was noted. Given the dependence of the clopidogrel metabolism on CYP450 system and the large number of the PPI available, including some that do not inhibit CYP2C19, extra vigilance should be taken when prescribing other agent with the clopidogrel. Prasugrel is the third generation P2Y12 ADP receptor blocker, also prodrug and the irreversible P2Y12 inhibitor. Prasugrel has the quicker onset of action when comparable to the clopidogrel. That is 30 to 90 minutes for prasugrel over 2 to 6 hours for clopidogrel. So the prasugrel has more predictable and more potent platelet inhibition than the clopidogrel. The trial to assess improvement in the therapeutic outcome by optimizing platelet inhibition with prasugrel. Thrombolysis in myocardial, that is Triton-TIMI trial, compared prasugrel to clopidogrel in 13,608 ACS patients who were scheduled to undergo PC. Notably, a study medication was administered after coronary anatomy was known, either during and after PC. So the patient who received prasugrel had 19% reduction of rate of cardiovascular death, MI, and stroke, as well as 52% reduction in stent thrombosis. However, these positive effects come at the price of significantly increased rate of major bleeding with prasugrel after PC. Comparable effects seen in the overall trial results were also seen among 10,074 patients with Nstemi ACS. So the prasugrel is contraindicated for patients with history of cerebrovascular event due to net harm in this subgroup, and there was no clinical benefit for patients older than 75 years of age and for patients who weighted less than 60 kg. The targeted platelet inhibition to clarify the optimal strategy to medically manage acute coronary syndrome, that is Trilogy ACS trial, evaluated aspirin plus either clopidogrel or prasugrel in Nstemi ACS patient managed medically without revascularization, and there was no difference in ischemic or bleeding event. As a result of this finding, for patients treated with PCI, who are not at high risk of bleeding, prasugrel is preferred over clopidogrel. Ticagrelor is the another Y12 ADP inhibitor. However, unlike clopidogrel and prasugrel, it has reversible binding and administered twice daily. Similar to prasugrel, ticagrelor has faster and more predictable onset of action. The Plateau trial compared clopidogrel and ticagrelor in 18,624 patients presenting with ACEs. Similar to overall trial, the subset of 11,080 Nstemi ACS patient, ticagrelor reduces the primary endpoint of cardiovascular death, MI, and stroke when compared with the clopidogrel. There was also a reduction in the rate of CV death and all-cause mortality. Bleeding outcome for subset of patients with Nstemi ACS were also similar to overall trial with no overall difference of major. However, ticagrelor group did not have higher rate of non-CABG related major bleeding. The lower events with the ticagrelor versus clopidogrel were independent of revascularization status within the first 10 days following randomization. So, two additional notable side effects observed from the Plateau trial were dyspnea and asymptomatic ventricular pauses that were not associated with increased rate of syncope or pacemaker implantation. So, ticagrelor is preferred over clopidogrel for patients treated with medical therapy or with PC. However, ticagrelor was tested head-to-head with prasugrel in patients with acute coronary syndrome from ISAR React 5 trial, and the incidence of death, MI, and stroke was significantly lower with prasugrel, and risk of major bleeding was not significantly different. So, nevertheless, these findings have not altered the present professional society guidelines. Now, the next P2Y12 inhibitor is canaglelor. Canaglelor is the intravenous P2Y12 ATP inhibitor with short half-life that is less than 10 minutes, that has fast and predictable onset and offset of action. Within the minute of initial dose, the desired antiplatelet effect is achieved, and within the 60 minutes of stopping infusion, the platelet function is restored. In the Champion Phoenix trial, there was significant reduction of composite of death from any cause, myocardial infarction, and ischemia-driven revascularization or stent thrombosis at 48 hours with canaglelor compared to clopidogrel, with result mainly driven from periprocedural stent thrombosis and MI. There was no increase in rate of gastro-defined severe bleeding, the primary safety endpoint. Canaglelol's short half-life with quick onset and offset make it appealing option for use as bridge for patient planned for surgery. The phase 2 pharmacodynamic bridge study evaluated the use of canaglelor as a bridge to CABG for 210 patients who had indication for thienopyridine treatment. Continuous infusion at a dose of 0.75 microgram per kg per minute provided comparable platelet inhibition to daily thienopyridine therapy. There was no increase in major bleeding complication. However, the study was not powered for clinical endpoint. The use of canaglelor as a bridge for non-cardiac surgery or for other clinical scenario appear to be attractive strategy, although it has not yet been evaluated in these additional settings. Although the use of P2Y12 inhibition in Nstemi ACS has become standard of care, the optimal timing of P2Y12 inhibitor administration remains quite uncertain. The previous guideline recommended that P2Y12 inhibitor therapy be initiated as soon as possible after diagnosis of Nstemi ACS. However, these recommendations were based on data from studies of clopidogrel, which is product for which clinical data suggests benefit to pretreatment. Subsequent to the very previous guideline, the only randomized control trial to evaluate the effect of the pretreatment with the P2Y12 inhibitor, the ACOS trial demonstrated no ischemic benefit with administration of prasugrel prior to angiography, where pretreatment was associated with increasing bleeding. As a result, prasugrel is not recommended prior to coronary angiography in patients with the Nstemi. In contrast, there are no randomized control data to support or refute pretreatment with either clopidogrel or ticagrelor. So pretreatment can cause logistical challenge in patients who end up requiring coronary artery bypass surgery, as a longer half-life can increase the bleeding risk up to 5 days after cessation. Given the lack of established benefit, the ESC guidelines do not recommend pretreatment with P2Y12 in patients with unknown anatomy who are undergoing invasive surgery. For patients undergoing non-invasive surgery, P2Y12 inhibition with clopidogrel and ticagrelor is recommended as soon as the diagnosis of Nstemi is made. Now, the duration of antiplatelet therapy. In general, the recommended duration of dual antiplatelet therapy is 12 months, but this may be adjusted in certain cases. For patients who have tolerated dual antiplatelet therapy well for 12 months, it may be reasonable to continue dual antiplatelet therapy for longer than 12 months. For patients who had been on dual antiplatelet for 12 months following PCI, dual antiplatelet therapy study demonstrated significant reduction in major adverse cardiovascular and cerebrovascular events with prolonged DAPT compared to aspirin alone. This benefit was consistent with the subgroup of patients with prior MI. This concept was reaffirmed in the prevention of cardiovascular events in patients with prior heart attack using ticagrelor compared to placebo and on the background of aspirin thrombolysis in myocardial infarction trial. The combination of aspirin plus two different doses of ticagrelor, that is 60 or 90 mmHg twice daily, reduce the composite outcome of cardiovascular death, MI, or stroke when compared with aspirin plus placebo among patients with prior MI more than 1 year before study end. The meta-analysis of dual antiplatelet for patients with prior MI also showed similar benefit with prolonged dual antiplatelet versus aspirin. Importantly, the prolonged dual antiplatelet did not increase the overall risk of bleeding. Shorter duration of dual antiplatelet with transition to P2Y12 monotherapy instead of aspirin monotherapy may be optimal. A recent meta-analysis has demonstrated that switching to P2Y12 monotherapy at 3 months resulted in reduced bleeding event and similar ischemic outcome. This is the Kaplan-Meier curve demonstrating the benefit of ticagrelor versus placebo in reducing the rates of major adverse cardiovascular events. Now the next is glycoprotein 2B3A inhibitor. Glycoprotein 2B3A inhibitor prevent the final common pathway of platelet aggregation, thus fibrinogen-mediated cross-linkage of platelet via glycoprotein 2B3A receptor. Currently available glycoprotein 2B3A inhibitor are all administered intravenously, including apixaban, eftifibatide, and tirofiban. The efficacy of glycoprotein 2B3A inhibitor for treatment of Nstemi have been evaluated by several studies. A meta-analysis of 6 random control trials demonstrated a modest 9% relative reduction of rate of 30-day death and MI with the use of glycoprotein 2B3A inhibitor. Notably, this benefit was predominantly seen in individuals who underwent PC. These trials, however, were largely performed before the era of the routine P2Y12 inhibition. So several trials have shown increase the rate of bleeding without significant reduction in ischemic event with early routine versus provisional use of glycoprotein 2B3A antagonist. So based on these data demonstrating no benefit but increasing bleeding with upstream initiation of glycoprotein 2B3A inhibitor, their role prior to PCI is limited. So the current AHA and ACC guideline provide class 2 recommendation that for high risk patient treated with early invasive strategy and dual antiplatelet and glycoprotein 2B3A inhibitor may be considered as a part of initial antiplatelet therapy. Alternatively, the current ESC guideline recommended against the use of glycoprotein 2B3A inhibitor for patients in whom coronary anatomy is not. and provide class 2A recommendation for their use during PCI in bailout situation and for thrombotic complications. Now regarding anticoagulation. Heparin. Among patients with Nstemi ACS, anticoagulation on the top of antiplatelet therapy reduces the risk of event. Unfractionated weight heparin is widely used anticoagulation that work by blocking both thrombin and factor Xa. So the unfractionated weight heparin is administered as a continuous infusion in patient with ACS owing to its short half. Meta-analysis showed that 33% reduction in the death or MI when comparing unfractionated weight heparin plus aspirin versus aspirin alone. The optimal regimen appear to be weight-based, weight-adjusted dosing, that is 60 unit per kg bolus with maximum of 4,000 and 12 unit per kg per hour infusion with maximum of 1,000 unit per hour with frequent monitoring of the activated partial thromboplastin time, that is every 6 hours until the target range and every 12 to 24 hours thereafter. Titration using standardized normogram with a target rate of APTT between 1.5 to 2.5 times control or approximately 50 to 70 seconds. Unfractionated weight heparin should be continued for 48 hours or until PCI is performed. Now regarding low molecular weight heparin. Compared to unfractionated weight heparin, low molecular weight heparin has a higher ratio of anti-10A to antithrombin activity and thus has more effective inhibition of the thrombin generation. Low molecular weight heparin has an additional potential advantage over standard unfractionated weight heparin. Low molecular weight heparin has a less binding with the platelet factor 4, heparin neutralizing protein, which may explain the lower rate of heparin-induced thrombocytopenia with the low molecular weight heparin versus unfractionated weight. Additionally, higher bioavailability and the more predictable dose response allow for the weight-based subcutaneous dosing without frequent monitoring. The recommended enoxaparin dose is 1 mg per kg every 12. Importantly, because enoxaparin is affected by renal dysfunction, dose adjustment is necessary for patients with reduced renal function. That is creatinine clearance of 15 to 30 ml per minute. Dose 1 mg per kg once daily. And low molecular weight heparin should not be used for patients with severe renal dysfunction. So several trials compared the unfractionated weight heparin with enoxaparin in patients with the Nstemi. So in the earlier study, the Essence and Timi demonstrated a reduction of ischemic event among patients treated with enoxaparin versus unfractionated weight heparin. Importantly, these trials were conducted on the background of predominantly non-invasive management strategy. So in contrast, subsequent superior yield of new strategy of enoxaparin revascularization and glycoprotein 2b3A inhibitor, that is synergy trial, conducted among high-risk Nstemi ACS patients who were planned for early invasive strategy, demonstrated no reduction in ischemic event with enoxaparin versus unfractionated weight heparin. So the enoxaparin was associated with increased bleeding. Given the differing result, the meta-analysis was performed, including 49,088 ACS patients that demonstrated a significant reduction in ischemic events with enoxaparin versus unfractionated heparin and no difference of the bleeding. Similar results were noted for subset of Nstemi ACS patients. Enoxaparin reduces ischemic event without increasing major bleeding. Now, the fondaparinux is the synthetic pentasaccharide and specific factor 10A. In the organization to assess strategies in ischemic syndrome, that is OSS 5 study, fondaparinux was found to be non-inferior to enoxaparin in terms of ischemic event and nearly half the rate of major bleeding over first 9 days in patients with Nstemi. By 30 days, mortality was significantly lower in fondaparinux. Notably, in the subset of patients undergoing PCI, fondaparinux was associated with increased risk of catheter-related thrombi. The standard dose of unfractionated heparin during PCI appear to minimize this risk, and consequently AHA-ACC and EAC recommended that standard dose unfractionated weight be used during PCI for patients treated with fondaparinux before. Now the next is bivalirudin. Bivalirudin is another antithrombotic drug used in the treatment of Nstemi, which act directly by inhibiting thrombin and thus inhibiting clot formation. Bivalirudin was evaluated in acute catheterization and urgent intervention triad strategy, that is ACUITY trial, which randomized 13,819 patients with Nstemi who were managed with early invasive strategy to one of the three treatments, that is unfractionated heparin or enoxaparin plus glycoprotein 2b3 inhibitor, or bivalirudin plus glycoprotein 2b3 inhibitor, or bivalirudin alone. The study found no difference of primary end point of death, myocardial infarction, unplanned revascularization for ischemia, and major bleeding at 30 days between bivalirudin plus glycoprotein 2b3 inhibitor and unfractionated weight heparin enoxaparin plus glycoprotein 2b3 inhibitor. So for bivalirudin alone group, when compared with the group receiving unfractionated weight heparin, enoxaparin plus glycoprotein 2b3 inhibitor, there was no difference in composite ischemic endpoint, but there was lower rate of bleeding. So similar results were noted for intracoronary stenting and antithrombotic regimen. A meta-analysis including 16 trial comparing bivalirudin-based regimen with heparin-based regimen demonstrated that bivalirudin was associated with reduction of bleeding event, but with increased risk of MI and stent thrombosis. The minimizing adverse hemorrhagic event by transradial access site and the systemic implementation of angiops, that is matrix study, demonstrated no benefit with bivalirudin with either major adverse cardiovascular event and or for net clinical adverse event. So the AHA and AACC guideline recommended that bivalirudin only be used for patient managed with early invasive strategy, where EAC guideline recommended bivalirudin as an alternative to unfractionated weight heparin, and glycoprotein 2b3 inhibitor during PCA. Now the next is oral anticoagulant. Oral anticoagulation with warfarin following ACS has been examined by the several trials because prolonged treatment might extend the benefit of early anticoagulation. Older trials showed that adding warfarin to aspirin lowered the rate of ischemic event, but the expense of increased bleeding. Likewise, adding full dose of apixaban to standard antiplatelet therapy following ACS significantly increased bleeding without reduction of ischemic event. In contrast, anti-TNA therapy at the lower cardiovascular event, in addition to aspirin with or without thienopyridine therapy in subject to acute coronary syndrome, Nstemi evaluated the effect of adding low-dose rivaroxaban versus placebo in 15,526 patients with recent disease. Roughly 50% of population had NCS-ACS, and 93% were on clopidogrel in addition to aspirin. And it included patients with history of intracranial bleeding, ischemic stroke, and transient ischemic attack. At mean follow-up of 13 months, the addition of rivaroxaban led to 16% lower rate of death, MI, stroke at expense of increased bleeding. The 2.5 mg dose led to increased 32% reduction in all-cause mortality, where 5 mg dose did not. Although both doses led to significant increase in bleeding, 2.5 mg dose had less of increasing bleeding risk than 5 mg dose. The COMPASS trial confirmed this result for patients with vascular bleeding, showing that 2.5 mg twice daily decreased the ischemic event and increased bleeding. As a result, 2.5 mg twice daily dose is available in Europe with Class 2A recommendation from ESC for patients with recent Nstemi ACS to be used in combination with aspirin and clopidogrel. Importantly, it is not recommended to be used in combination with ticagrelor or prasugrel and is contraindicated in patients with history of ischemic stroke and TI. Patient on the chronic oral anticoagulation for atrial fibrillation or prior deep vein thrombosis and pulmonary embolism require additional consideration in setting with Nstemi ACs. On presentation, unfractionated heparin should be deferred until the patient is subtherapeutic or due to their next dose. Following PCI, the combination of dual antiplatelet with oral anticoagulation, also known as triple therapy, causes high rate of bleeding. Instead, the short course of triple therapy with aspirin, clopidogrel, and direct oral anticoagulation should be transitioned to clopidogrel plus direct oral anticoagulation after approximately 1 week or 4 weeks in patients with high ischemic risk and low bleeding risk. Now, regarding anti-ischemic therapy, patients who are in respiratory distress or have arterial oxygen saturation less than 90% should have received supplemental oxygen. Previous guideline recommended for routine use of supplemental oxygen in all patients with Nstemi during first 6 hours after presentation, even in the absence of low arterial oxygen saturation. In normoxic enstemiasis patient, there is no evidence that routine supplemental oxygen is beneficial. However, there is evidence of potential harm with routine supplemental oxygen among normoxic STEMI patients. Nitrate can be helpful for management of ischemic symptom of patient with enstemiasis. Importantly, they are provided for symptom relief and do not impact mortality benefit. Both Gruppo Italio Perlo, that is GCC3 and international ISIS-4 trial failed to demonstrate survival benefit with nitrate for patients with confirmed and suspected ACEs. So if there is persistent pain and hypertension after 3 sublingual tablets and initiation of beta blockage, intravenous nitroglycerin is recommended. Nitrate should not be given to patients who have recently taken phosphodiesterase inhibitor because of increased risk of hypotension. Now, the next anti-ischemic therapy is beta. Beta blocker lowers heart rate, blood pressure, contractility, leading to the decreased myocardial oxygen consumption. A meta-analysis demonstrated that early initiation of the beta blockage was associated with the reduction of ischemic event and modest reduction in the near-term all-cause mortality. The clopidogrel and metoprolol in myocardial infarction trial, that is COMET, demonstrated the importance of selecting the right population for early initiation of beta blockage in ACEs. In overall population of 45,852 patients, the beneficial effect of metoprolol on reinfarction and ventricular fibrillation were balanced by increased risk of cardiogenic shock. When population was stratified according to the risk of cardiogenic shock, those considered low risk demonstrated significant benefit associated with early initiation of beta blockage. The clinical feature identified a high risk of cardiogenic shock included age more than 70 years, systolic blood pressure less than 120 mmHg, heart rate more than 110 beats per minute, and over heart failure on initial examination. The current guideline recommended for initiation of oral beta blockage within the first 24 hours for patients who are not in heart failure, state of low cardiac output, and high risk of cardiogenic shock and significant AV. For patients with initial contraindication to early beta blockage, once the patient have hemodynamically stabilized, the initiation of beta blockage should be considered. Additionally, a history of chronic obstructive lung disease or asthma is not contraindication to initiation of beta blockage in the absence of active airway disease. Now the next is calcium channel blocker. Non-dihydropyridine calcium channel blocker, that is diltiazem and verapamil, have minimum role in the patient with enstemiasis. While 2 trials have shown a reduction in the incidence of recurrent MI, others have not shown the benefit with calcium channel blockage. In fact, in patients with acute MI with significant LV dysfunction or heart failure, harmful effects have been observed with administration of diltiaz. In addition, short-acting nifedipine, that is had shown to have harmful effect for patients with acute MI and is not recommended for patients with Nstemi. Thus, current guideline recommended that non-dihydropyridine calcium channel blocker be used only for patients with preserved LV function and without heart failure, and then only if needed for recurrent ischemia despite the use of nitrate or beta blockage, and for patients in whom beta blockage is contraindicated. So calcium channel blocker should not be administered to patients at risk for cardiogenic shock or with significant AV block. Now the next anti-ischemic drug is ranolazine. Although the exact mechanism of its anti-anginal effect is unknown, ranolazine has been shown to partially inhibit the fatty acid oxidation and may improve the efficacy of the oxygen utilization in cardiac myocyte. After a rule was established for stable angina, the metabolic efficiency with ranolazine for less ischemia in the Nstemi, that is Merlin trial, expanded the use of ranolazine to Nstemi ACS population by evaluating 6,560 patients with Nstemi ACS. Out of which 3,279 were randomized to receive ranolazine and 3,281 received placebo. Although there was no difference in primary endpoint between the two groups, there was significant reduction in the rate of recurrent ischemia with ranolazine and angina syndrome. So ranolazine remains an attractive addition to beta blocker and nitrate for treatment of chronic severe angina. Then the next drug is angiotensin converting enzyme inhibitor that have been shown to reduce the mortality for patients after MI who have either LV systolic dysfunction or heart failure. A meta-analysis of 1 lakh patients demonstrated a statistically significant small decrease in 30-day mortality with early initiation of AC inhibitor following MI. So benefit was seen as early as 24 hours. However, there was also increase of hypotension and renal dysfunction seen with early initiation of AC inhibitors. These results suggest the AC inhibitors may be the safety initiated early following MI, but the benefit must be weighted against the risk of hypotension and renal dysfunction. The current guideline recommended the use of AC inhibitor for patients with Nstemi ACS with systolic dysfunction, heart failure, hypertension, diabetes, and stable CKD. Now, the next drug is ARB. ARB provides an alternative to AC inhibitor and may block the renin-angiotensin system more completely than AC. Because angiotensin 2 can be generated via pathway that are independent of AC inhibitor. So the valsartan in acute myocardial infarction trial, that is Valiant trial, randomized nearly 15,000 patients with recent MI complicated by heart failure to receive ARB and AC inhibitor or combination of the two drugs. So valsartan found to be non-inferior to captopril at 2 years with regard to mortality and recurrent cardiovascular event. These findings were confirmed in the ongoing telmisartan alone and in combination with ramipril global endpoint trial. Hence, ARB was effective alternative for patients who are intolerant to AC. Now, the next is mineralocorticoid receptor antagonist. Aldosterone blockage, in addition to AC inhibition, lower the rate of all-cause mortality of patients with severe heart failure and reduced systolic function. The main adverse effect of aldosterone blockage is hyperkalemia. The eplerenone post-acute myocardial infarction heart failure efficacy and survival study, that is FSS trial, randomized 6,642 patients stabilized from recent MI with LV dysfunction plus heart failure, diabetes to receive eplerenone versus placebo in addition to optimal medical therapy. At 24, eplerenone led to 30% reduction in all-cause mortality. Aldosterone blockage is recommended for patients with post-MI who are receiving AC inhibitor, beta blockage, and with the ejection fraction of less than 40%. and either heart failure and diabetes. It is not recommended for patients with renal dysfunction, men with creat more than 2.5, and for female with the creat of more than 2, and hyperkalemia with potassium of more than 5. Now the next is lipid lowering therapy. All patients with Nstemi should have statin long term. The benefit of this first line lipid lowering therapy are well established and strongly support early initiation of high intensity statin. More recently, improved reduction of outcome, that is, improve it, evaluated the effect of ezetimibe plus simvastatin alone for stable patient with recent disease. The addition of ezetimibe reduces the LDL, um, that is 54 in ezetimibe and simvastatin group versus 70 in simvastatin monotherapy group. Over 7-year follow-up, there was a 6.4% relative risk reduction of recurrent ischemic event for combination therapy group versus monotherapy group. The relative risk reduction was consistent with what was expected based on the degree of LDL cholesterol load. The current AHA, ACC, and ESC cholesterol guideline recommended ezetimibe as adjunctive lipid lowering therapy for patients not at their LDL-C target despite maximally tolerated statin. Similarly, proprotein convertase subtilisin Kexin 9 inhibitor, that is evolocumab and the alirocumab, have been shown to reduce major cardiovascular event when added to statin therapy in patients with history of MI. So this is the Kaplan-Meier demonstrated the benefit of ezetimibe when added to simvastatin versus simvastatin alone. So routine invasive versus ischemia-guided strategy of coronary angiography and revascularization. This two general approaches to the use of coronary angiography and revascularization in Nstemi exist. So the first is routine invasive strategy involving routine coronary angiography within first 72 hours and revascularization with PCI and bypass as appropriate. The other is more conservative approach with initial medical management with coronary angiography and revascularization only for recurrent ischemia, which could be termed as ischemia guided strategy. Several trials have compared these two treatment strategies, and overall routine invasive strategy lowers the risk of ischemic event compared with ischemia guided approach. A 7 trial meta-analysis demonstrated that 25% lower rate of death and 70% lower rate of MI over 2-year follow-up with routine invasive approach. A subsequent meta-analysis, including 8 trials, demonstrated similar findings with 22% lower rate in composite of death, MI, and rehospitalization for ACS over 1-year follow-up. A second meta-analysis demonstrated that various men overall seem to be benefit from routine invasive approach. The only high-risk women benefit from the routine invasive approach, and low-risk women had non-significant trend towards harm with the routine invasive approach. The current guideline reflect this finding and recommended routine invasive approach for patients, except for those who are at low risk, notably low risk female without elevated troponin. So this table is demonstrating the risk criteria with invasive and ischemia guided management strategy. So urgent invasive strategy, that is within 2 hours, is needed in very high risk cases, which includes hemodynamic instability, sustained VT, VF, refractory ischemia, acute heart failure, and mechanical complication. Then early invasive, that is within 24 hours, is needed in high risk patient, that is Grace risk score of more than 140 and elevated troponin consistent with MI. Then delayed strategy, that is between 24 to 72 hours, is indicated in intermediate risk, that is diabetes, renal insufficiency with EGFR for less than 60 ml, reduced LV function, that is ejection fraction of less than 40%, prior PCI CABG, Grace risk score between 109 to 140, TIMI risk score of more than 2. Then ischemia guided is needed in low risk patient, that is GRACE risk score of less than 109, TIMI risk score of less than 2, low risk proponent negative, low risk proponent negative female patient. Now, early versus delay, the invasive routine strategy have generally defined coronary angiography within 72 hours. However, the key question is whether patient benefit from early invasive strategy, that is within 24 hours, or delayed invasive strategy, that is within 24 to 72 hours. So, two meta-analyses attempt to address this question and demonstrate no benefit for death or MI. However, both demonstrated lower rate of recurrent ischemia with early invasive strategy. So these there are data suggesting improved outcome with early invasive strategy for high risk Nstemi ACS patients. The TMAC trial showed a randomized 3,031 patients with Nstemi ACS to undergo early invasive strategy versus delayed invasive strategy. That is early, that is coronary angiography within 24 hours, and delayed means coronary angiography of more than 36 hours after randomization. Although the primary endpoint at 6 months was no difference between two groups, the pre-specified analysis according to the GRACE risk score demonstrated a significant 35% reduction in primary endpoint for high-risk patients with GRACE score of less than more than 140. Accordingly, the guideline recommended Nstemi ACS patients at high risk should undergo early invasive strategy within first 24 hours of presentation, while remaining individuals should undergo coronary angiography within 72 hours of presentation. Thank you.